Around the world with MS World, I'm Dr. Daniel Kantor. We've been here all week at the American Academy of Neurology annual meeting in Boston, Massachusetts. It's the 69th annual meeting of the American Academy of Neurology, and we not only hear about multiple sclerosis, we also hear about all fields in neurology, but there has been a lot of research that's gone on in MS in the past year, in the past 2 years, and in fact, in the past several decades. That's why I'm so happy to be joined here by my esteemed colleague. I'm joined by Dr. Ed Fox, who is the director of the MS Clinic of Central Texas, near Austin, Texas. We're joined by Dr. Sam Hunter, who is the president of Advanced Neurosciences Institute in Franklin, Tennessee. We're joined by Dr. Doug Jeffery, who is the director of the MS Center at Piedmont Healthcare in Lake Norman Neurology. And finally, we're excited to be joined by Dr. Barry Singer, who is the director of the MS Center for Innovations in Care at Missouri Baptist Medical Center. Thank you all so much for joining us today. We've heard about a lot of research, but I think we should start with getting an idea from you. What's been the most exciting research that either you've presented this week, because many of you, and in fact all of you, have presented at various times and sometimes multiple times during this week, or what are some of the other research that you've seen that's really been exciting for you? Let's start with you, Ed. What do you think?
This has been the first meeting in a while that I can say there's been a real balance in the research that's been given in terms of what is the cause of MS and who gets worse MS than others and what environmental changes we can make and also what our chances are for remyelination. And so it's hard to actually say there's one thing that stands out in my mind because I think we're getting a better balance now. We have so many therapies out for MS, but there is so much in the future that could come out. And I think that what I'm leaving with is a lot of little pieces of knowledge that I think are helping build a bigger picture of the disease.
Dr. Doug Jeffery, what do you think? What's really been exciting for you this week?
So there are several things that I found really exciting. First, we presented the Tysabri secondary progressive data, and this was a reanalysis. And one of the things we looked at is the proportion of patients with secondary progressive MS who had significant physical improvement. And we found that quite a substantial proportion of that population actually improved on this medication, natalizumab, despite the fact that overall the clinical trial was negative. So that was very exciting, and I was very pleased to be a co-author on that paper. One of the other things that I thought was very exciting was a very preliminary paper given on cytotoxic T lymphocytes, which are directed against the Epstein-Barr virus. The Epstein-Barr virus is a virus which is epidemiologically very closely associated with multiple sclerosis. In certain meta-analysis, the hazard ratio for having MS, if you haven't been exposed to Epstein-Barr virus, is 0. So this tells us that having exposure to Epstein-Barr virus is probably a prerequisite to having MS. So B lymphocytes will sometimes contain Epstein-Barr virus, so that's where the virus resides once people have been infected with the Epstein-Barr virus. And it's a very common infection. About 90 to 95% of the general population have been exposed to Epstein-Barr virus and 100% of the MS patient population. So one of the ideas that has always been sort of trickling up is that maybe MS is caused not so much directly by Epstein-Barr virus infection, but by cellular products that are produced by the Epstein-Barr virus, such as microRNAs and other proteins. So what this cytotoxic T lymphocyte does is it is targeted against cells which are infected by Epstein-Barr virus. And so there's an enormous therapeutic potential for this drug, for this treatment in multiple sclerosis. So there were preliminary data that were presented showing that 5 patients who with primary and secondary progressive MS actually had very positive responses to treatment with significant clinical improvement. So this is very exciting stuff. And then there were this additional exciting work presented on siponimod, which is a drug like fingolimod for secondary progressive MS, and then of course Ocrevus, the most recently approved MS medication, which was effective in primary progressive MS.
Dr. Sam Hunter, what do you think? What's really been interesting for you, Sam, at this meeting?
Well, I think there's an evolving concept that progressive MS can be prevented, and when it's occurring, we can treat it, and that our treatments were probably more effective than what we perceived when you analyze the data, because the requirements for what you measured was not specified by the things that were likely to change in the short period of time that we were going to be able to measure them. So, for example, arm function seems to get better. We've seen a few positive trials, and actually is some of the agents people are very familiar with, and getting some confidence that we can change the future for people with progressive MS looks very realistic right now. And the other thing that was very impressive in this meeting was in the people who were treated with Lemtrada, essentially nobody develops progressive MS, but when you look at them in the long term, in 6 years after starting treatment.
Dr. Barry Singer, what's really been exciting for you?
Well, some of the data, actually, Dr. Fox and I did back-to-back presentations and looked at some of the Lemtrada data. So people that got 2 infusions, one at the beginning and then one year later. If you follow those patients out 6 years, we found that 80 or 81% of the patients actually had stable disability or actually improved in disability. So one of the exciting things, as you can see, up to 43% of these patients that had previously been on treatment got Lemtrada, and you followed them at 6 years. 43% of people actually had less disability than when they began. So that was exciting data to present. And then one of the other presentations I did was on the new treatment, Ocrevus. And we talked a little bit about primary progressive MS. And unfortunately, this has been a category where we failed with numerous medications. So again, it was exciting to see Ocrevus. This is actually the first meeting, national meeting on it since it got approved. So we talked about some of the data about how Ocrevus is going to impact the people with primary progressive MS plus relapsing MS. One of the other data that was shown was looking at relapsing MS. People that were on an interferon and then switched to Ocrevus, and you saw a dramatic drop in MRI activity to the point where very few people had any active MRI scans. So it's an impressive way forward. But I think the real goal is we're making headway in progressive MS. Siponimod was mentioned for secondary progressive MS, and now Ocrevus for primary progressive MS. So we're seeing some major breakthroughs in progressive disease.
I think one of the interesting things to see is how at the same meeting there can be so many different topics that we all find so interesting and so exciting. At MS World, we receive questions from people back home. And one of the questions people have is, how close are we to a cure? And if we did have a cure, would it actually be available? Would it actually be accessible to people? Sam, what's your take on that?
Well, we already have medicines that have been used which produce freedom from long-term disease activity in a majority of patients, and ones that actually improve disability. What we wanted was treatments that make people better. We have several treatments which seem to make a fraction of people better and produce freedom from long-term disability. They are not cures for the disease. Curing this disease means a lot more than just fixing the big problems. The invisible symptoms that people have with MS, their fatigue and their mood and their sleep, those affect quality of life. Those are very hard to make better, and we have ongoing research in those areas, but the disease-modifying therapies seem to be able to address the worst of the disabilities with MS.
Barry, what do you think? How close are we to an actual cure, and what would that cure look like, and would we actually have it for our patients? Would it be accessible?
Well, there wasn't much of this meeting for looking at the cure, but I think it's still doable. We're starting to learn there's a genetic component to MS and a genetic background that makes you more susceptible to developing MS. And we know numerous environmental triggers, vitamin D, Epstein-Barr virus. We just came out of a session that we were looking at all these risk factors. So I think we're going to need a personalized approach, something where we're looking at the genetic background of an individual with MS, and then maybe we're going to have a custom vaccination for that person to prevent the disease from going forward. So I think it is going to have to be personalized. It's not a specific virus. We're not fighting one virus that attacks the body and you can get a simple vaccine and do it. We have to look at your own genetic background and really come up with an individualized, personalized approach, I think is the only way that we're going to cure MS.
Ed, how close are we to a cure?
I've always felt that there are three possible ways you could say there's a cure for MS. One is to say that we have a means of prevention so that the current generation will be the last generation to ever be afflicted with the disease. That means that we'd have to understand the cause of the disease to an extent that we would be able to alter the future for future generations. The second one is, as Dr. Hunter said, if we could take individual patients now and give them a medicine that gives them not just a high degree, but a very high probability that they are going to have no future disease activity during their lifetime, then maybe for that newly diagnosed patient, you have said that you've cured them. But lastly, and the most importantly, I think, to anybody who's watching, is what can we do to reverse the damage that's already occurred? And that's the most problematic, to get normal tissue back again. And so I always want to caution people about the use of the word cure, because I think that we are very close, if not there, for a number of patients to be able to say we're arresting the disease in a lifetime. I think that we are getting closer to understanding the causes of it, so we may be able to modify risk factors to substantially reduce the chance of getting MS in the future. But the ability to regrow brain tissue, which is where we get into discussions of stem cells and so on, I think that we are still making very small strides towards it every year.
Doug, what do you think? Are we close to a cure?
Maybe and maybe not. I think probably not. So we don't even know what causes MS. Many people talk about MS as though it's an autoimmune disease, and we don't know that it's autoimmune. That's never been proven. I disagree with Barry a little bit, and he thinks it's maybe a number of different viruses involved. But from my read of everything that's going on, Epstein-Barr virus really does seem like the virus that's the trigger for MS. 100% of the MS patient population has Epstein-Barr virus exposure, compared to only 90 to 95% of the normal non-MS patient population. And your hazard ratio for having MS, if you don't have Epstein-Barr virus exposure, is 0. So one of the treatments that I mentioned earlier that's really so exciting is the cytotoxic T lymphocyte, which is directed against Epstein-Barr virus infected cells. Theoretically, if you could eradicate Epstein-Barr virus infected cells from somebody's body, that could possibly cure MS. It doesn't reverse the damage that's already done. So that's way off in the future, and it's a hope of hopes. We just don't know. That being said, I'd like to reiterate what everybody else said, is that the drugs we have in this day and age are good enough that it's tantamount to a cure, because we can absolutely prevent progression in the overwhelming majority of the MS patient population.
And I can tell you that this look for a cure is not something that just patients want. It's what doctors want. There's not some hidden notion that we want there to be people who are sick with multiple sclerosis. If any of us could cure multiple sclerosis, it would be something we would do. And if any of us knew that there was a cure and it wasn't accessible, I think all of us would be mobilized to be fighting for you back home. One of the questions that we get from MS World viewers has to do with the genetics of multiple sclerosis. Although we say that MS is partially genetic, partially environmental, there are some people who have multiple family members with multiple sclerosis. Dr. Fox, how do you think we explain that? Does that mean they have a different type of multiple sclerosis, or is there something else going on?
The immune system is definitely under genetic control. So when they've looked at linkage in this disease, what they always do is they look at an affected parent, an unaffected parent, and then the child that has MS. And they want to find out, what have they inherited from the parent that has MS and didn't inherit from the parent that didn't have MS. They call that a triad. It's a really good way of looking at the genetics of a disease. And every single gene that they have associated thus far has been within the immune system. So my argument about it being an autoimmune disease is that it's certainly an immune disease. Even if you're not going to call it autoimmune, as a guarantee, we certainly can link it to the immune system. So I think that when we're looking at specific alleles, there's one that comes up over and over again, and that's HLA, DR2, and the allele 1501, and it's associated with Epstein-Barr virus infections, and that if you have Epstein-Barr virus infection and you have that genetic, you may be at a much greater likelihood of developing an aberrant or an abnormal immune response against that virus that might trigger the autoimmunity. So do I think that we have clear association with genetics? Yes, and we know that from twins. Because if one identical twin has it, the other has about a 1 out of 3 chance of getting it, whereas if it's fraternal twin, it's only 4%. So that difference between identical and fraternal twins, in my mind, is enough proof that it's genetic.
At MS World, we receive a lot of questions that have to do with the regular symptoms of multiple sclerosis, and it may not be something that we necessarily cover in large scientific meetings. But Sam, when you have a patient with trigeminal neuralgia, what are the range of options that you have for them?
Well, trigeminal neuralgia, fortunately, is one of our symptoms that's been researched to a greater deal. And trigeminal neuralgia in MS is thought to occur because the nerve is mildly injured from the MS process, and it becomes more vulnerable to the injury from a blood vessel laying on top of it. And in almost all cases, trigeminal neuralgia, the classical syndrome, is caused by a small blood vessel laying on top of the nerve and further damaging it. It's very vulnerable near the base where it comes out the brain. We use a drug called carbamazepine, used to be called Tegretol. We use other medicines in the seizure family or baclofen as first-line medications, but there are a number of surgical procedures that are used, some which are quite old that involve blocking the nerve or damaging it through a simple procedure that's done as an outpatient, and some that are more involved that involve a more the delicate surgery to move the blood vessel off the nerve. And a combination of these strategies, and sometimes even afterwards in failures with a special kind of computer-directed radiation, are used to and can stop the trigeminal neuralgia in most cases or make it much simpler to manage. Now, trigeminal neuralgia does occur just in the setting of a relapse sometimes, and sometimes all it's needed is medication for a short time and steroid treatment for a relapse to get it to go away.
At MS World, we receive questions that have to do with sleep and multiple sclerosis. Dr. Singer, when you have a patient with multiple sclerosis and they have a sleep disorder, is there anything that we can do to offer them? Do you check your sleep in patients with multiple sclerosis?
Yeah, so sleep is a big issue. Well, first of all, 90% of people with MS have fatigue. So the first thing I ask is, how well are you sleeping? Because if you're going to be tired all day, maybe it's because of sleep problem. And I see an array of problems. Some are anxiety. People get anxious. They can't settle down. Their mind keeps rolling, so we have to work on that. Other people have restless legs. Their legs are moving around at night, and they're kicking their significant other. So we have to control restless legs. Obstructive sleep apnea is very common, so people snore and stop breathing during the night. So then we have options to help control that. So we definitely work on sleep, and some people require a sleep study to kind of figure that out. But one of the important things is try to get good sleep, because if you get good sleep, then your fatigue is going to be much better during the day. If the sleep doesn't work, and you're still getting good sleep and you're still tired during the day, then we can talk options to control that, such as exercise can reduce fatigue during the day, and just fatigue management, and sometimes medications.
MS viewers wrote in and asked questions about having other sorts of conditions in addition to the multiple sclerosis. People asked about what are the chances of somebody also having cerebral palsy and having multiple sclerosis? What about having other autoimmune disorders or connective tissue disorder? Dr. Jeffery, when you have a patient that has MS but has something else going on, what do you tell them?
So usually it's unrelated. So if you look in large studies where in families of patients with multiple sclerosis, so one Finnish study looked at 17,000 people, and they found that in patients with MS, the family members did not have a higher incidence of other autoimmune diseases. And this finally laid to rest a long-standing controversy about whether or not that was true. So when patients with MS have other diseases such as rheumatoid arthritis or psoriasis, what we try to do is we try to find one drug that will work for both disease states. Sometimes that can be really difficult. There's other comorbidities too that actually can worsen disability in multiple sclerosis. So if somebody has metabolic syndrome or type 2 diabetes, their time to disability progression is much more rapid than those patients who don't have a metabolic syndrome or type 2 diabetes. So there's really a lot of work to be done there, and there's a lot that we don't really understand, but we have a general sense and some good scientific data that certain other diseases may affect how rapidly patients with MS progress.
From all of us at MS World, I want to thank our all-star panel. I want to thank Dr. Barry Singer. I want to thank Dr. Doug Jeffery. I want to thank Dr. Sam Hunter and Dr. Ed Fox. And most of all, I also want to thank you back home for your amazing questions and really your dedication to following us throughout time. We started this with a flip cam in 2009, and we've come so far. Thank you, and see you at the next meeting.